Good evening, all. My name is Kumara Sidhartha. I'm a physician, medical director at the Cape Cod Healthcare Accountable Care Organization. And I would like to welcome you all to this Wellness Trails event of 2022, where we are bringing back the Wellness Trail event after quite a long pause from the pandemic period. The last one we had on this Wellness Trails series was early 2020, just before the pandemic started. So we are thrilled to bring this program back to you in the virtual format because of the continuing waves of the pandemic. And aligning with this month's Breast Cancer Awareness Month, the Wellness Trails is returning to you on the theme of prevention of breast cancer and education and awareness around that. I would couple of thoughts I would like to share. One is making sure that if you have questions throughout the presentations today, you can use the chat box to type in your questions, and we will address your questions at the end of the presentation. And you can also watch the recording of this video if you missed any pieces, or if you want to share it with others. It'll be posted by this weekend. You could start watching it starting this weekend at the Cape Cod Healthcare website. That'll be www.capecodhealth.org/breast-care. So there you can find this video recording. And for today's program, we're going to kick it off with a presentation by Dr. Jill Oxley, who is a breast surgeon at Cape Cod Healthcare and is also the director for the breast care services in Cape Cod Healthcare. So Dr. Oxley will be covering important topics related to screenings for breast cancer, the genetics and evaluations around that. And we are fortunate to have her expertise today at this program. So without further ado, I will kick off the program to Dr. Oxley.
Thank you, Dr. Sidhartha. So we'll spend the next part of the evening talking about advances in breast cancer screening, risk assessment, and a little bit on treatment. We'll address why breast cancer screening is important, some of the more recent guidelines for screening, what it really means to have a breast cancer risk assessment, and then some of the advances in breast cancer treatment. So the American Cancer Society estimates for this year, there will be over 1,919,000 new cases of invasive cancer diagnosed in the US. Over 287,000 of these will be invasive breast cancer, with another 51,400 cases of non-invasive breast cancer or ductal carcinoma in situ. For Massachusetts, over 422,000 new cases of invasive cancer will be diagnosed, and 6,710 of these will be female breast cancer. That is the most commonly diagnosed cancer in Massachusetts, as well as the most commonly diagnosed cancer in women, followed by prostate, lung, and colorectal cancer overall. The American Cancer Society also estimates for this year there will be over 609,000 deaths from cancer in the United States. That makes cancer the second most common cause of death behind heart disease, but is actually the most common cause for women between the ages of 40 and 79 and men ages 60 to 79. 1/4 of all deaths in the US are due to cancer. And in Massachusetts, again, there'll be 12,520 estimated cancer deaths, but fortunately, female breast cancer is number 4, behind lung, pancreas, and colon cancer. And so to look at those numbers in a slightly different format, with men on the left and women on the right, you can see that breast cancer is the most commonly diagnosed cancer in women at 31%, or nearly 1/3 of cancers diagnosed, which means that a woman has a 1 in 8 chance, or 13% chance of being diagnosed with breast cancer in her lifetime. And breast cancer is illustrated by the lower arrow, is the second leading cause of cancer death, accounting for 15% of cases, or 1 in 39 women will die from breast cancer. And so incidence rates mean how many cases are diagnosed per year. And so for the most recent 5-year data, and this is data from the American Cancer Society, National Cancer Institute, and Massachusetts Cancer Registry data, in the US, there are 126.9 cases diagnosed per 100,000 women. The rate in Massachusetts is higher, 136.9 cases, with Barnstable County even higher at 156.1, number 2 behind Nantucket County. The overall incidence rates are increasing by about 0.5% per year. But fortunately, the death rate has been decreasing between 1.3 and 1.9% per year, with an overall decrease of 43% since 1989. And this is in large part due to the detection of cancer at earlier stages. And so when we're talking about screening, we're talking about prevention. And primary prevention deals with modifiable risk factors. But secondary prevention is in large part through screening mammography. And mammography saves lives. Mammograms are the only test shown to reduce deaths from breast cancer in 9 randomized controlled trials over the last several decades. 3D mammography, or digital breast tomosynthesis, detects more cancers and recalls fewer patients than 2D digital mammography, especially in women who have dense breasts. And we know that annual screening between the ages of 40 and 84 reduces the risk of dying from breast cancer by 40%. 1 in 6 breast cancers are diagnosed in women in their 40s. 1/3 of breast cancers diagnosed in Black, Asian, and Hispanic women, and 1/4 of breast cancers diagnosed in white women are diagnosed under the age of 50. 75% of women who develop breast cancer are considered average risk. And fortunately, the risk of needing a needle biopsy of a benign lesion found on a screening mammogram is only 1% per year. Now, the risk of breast cancer does increase with age until the 70s, but the risk of death continues to increase into the 80s. Cancers that are detected on routine screening are usually more favorable than cancers that are detected by either symptoms or between routine screening mammograms, meaning more likely smaller, hormone-sensitive cancers with better outcomes. 2/3 of all invasive cancers are limited to the breast at diagnosis, and over 90% have not spread beyond the axillary lymph nodes, or lymph nodes in the underarm, which is the first site of spread. Survival is highly dependent on the stage at diagnosis. For stage 1 cancer, the 5-year survival is over 99%. For stage 2, 93%, stage 3 is 75%, and stage 4 at 29%. And so if screening mammograms save lives, how are we doing with screening? Well, that depends on who you ask. The American Cancer Society guidelines recommend annual screening mammography for women who are at average risk starting at age 45, whereas the U.S. Preventive Services Task Force recommends screening every other year for women only between the ages of 50 and 74. So by the American Cancer Society guidelines, 65% of women are up to date with screening. And this ranges from a low of 56% in Alaska and Wyoming to a high of 76% in Hawaii. And we're doing pretty well in Massachusetts, with 75% of women considered up to date. By the less stringent guidelines, 76% of women are up to date, with a range of 60% in Wyoming at the low, up to the high of 80% here in Massachusetts. But there are lots of guidelines out there. And this slide is intentionally busy. This is from the CDC website. And the U.S. Preventive Services Task Force and American Cancer Society guidelines, as we just talked about, are both on there, along with the American College of Obstetricians and Gynecologists, International Agency for Research on Cancer, American College of Radiology, American College of Physicians, and American Academy of Family Practice. And the first group across the top talks about women who are at age 40 to 49 with average risk. And again, this slide is intentionally busy, but there's lots of disagreement on what to do. Women aged 50 to 74 with average risk, again, lots of disagreement on recommendations. But the American College of Radiology puts it quite simply. Screening mammography is recommended once a year for women 40 to 49 and then 50 to 74. Well, what about older women? Women who are 75 and older at the top of this chart here, there's lots of comments on insufficient evidence or not addressed. But again, the American College of Radiology says that for women who are older, the age to stop screening depends on her health, not her age. And then what about women with dense breast tissue? Again, lots of these guidelines say insufficient evidence or even evidence against supplemental screening. But the American College of Radiology recommends contrast-enhanced MRI in addition to mammography for women with dense breasts, and to consider ultrasound if an MRI is not available. And then what about women who are high risk? The CDC just summarizes that some groups recommend different guidelines. And so let's talk about these guidelines a little bit more. The American College of Radiology and Society of Breast Imaging updated their guidelines in 2017 to the ones that we just mentioned. The American Society of Breast Surgeons updated theirs in 2019, and earlier this year, the National Comprehensive Cancer Network updated their guidelines for patients as follows. Women who are at average risk of developing breast cancer should have annual screening mammograms starting at age 40, but more importantly, should have a formal risk assessment at age 25 or no later than age 30, especially for women who are of Black or Ashkenazi Jewish ancestry. And so this is going to help us figure out if someone is at high risk or average risk. And then how does breast density play in? As women who have dense breast tissue may benefit from supplemental screening. So all the states now require reporting of information about breast density, but with different amounts of information included. Connecticut was the first state to mandate this back in 2009. Massachusetts began reporting breast density in 2015. And in 2019, the Department of Health and Human Services and FDA changed the Mammography Quality Standards Act to include reporting of dense breast tissue. And again, this would allow women access to supplemental screening. Radiologists classify breast density into 4 categories, A through C, with the least dense breast being called almost entirely fatty, and then scattered areas of density, heterogeneously dense tissue, and extremely dense tissue. And the distribution is in this pie chart below, with approximately 10% of US women having extremely dense breasts, 40% heterogeneously dense, 40% scattered, and 10% almost entirely fatty. And the lower 2 categories are not dense, the higher 2 are. So roughly 50% of American women have dense breast tissue. And having dense breast tissue may increase the risk of breast cancer, especially in postmenopausal women. But a cancer may be harder to see on a mammogram in dense breasts. And again, 3D mammography has been shown to be better than 2D mammography for women with dense breast tissue, and that's available at all of the Cape Cod healthcare facilities. And supplemental screening, again, when indicated, is generally preferred for an MRI, but ultrasound and MRI are more likely to detect things that are not cancer. And so without getting into statistical terminology, that's why those 2 exams won't replace mammography for routine screening for everyone. And MRI exams are available for women who are at increased risk of breast cancer, but for someone who has dense breast tissue but otherwise is not considered high risk, Cape Cod Healthcare offers fast MRI screening, which unfortunately is not yet covered by insurance, but is a fairly reasonable out-of-pocket expense. And so dense breast tissue is, of course, a large part of screening, but there are lots of risk assessment models out there to really fine-tune someone's risk. The National Cancer Institute Breast Cancer Risk Assessment Tool, or GALE model, estimates both the 5-year and the lifetime risk of developing an invasive breast cancer. Using this model, you input the patient's current age, information about onset of menstruation, age at the first live birth, first-degree female relatives with breast cancer, the patient's number of previous breast biopsies, and whether or not any of those biopsies had atypia. But this model does not include a history of lobular carcinoma in situ. It does not include any male relatives or paternal relatives, and does not include relatives with ovarian cancer. This model does not estimate the risk of harboring genetic mutation, specifically BRCA gene mutations, and may underestimate the risk in women who are Black or of Hispanic descent. But this model is useful for recommendations for chemoprophylaxis, for if someone has a calculated 5-year risk of breast cancer greater than 1.7%, they would qualify for prophylactic endocrine therapy. The Klaus model is similar to the Gale model, but only includes the patient's age and not any other personal factors. It does include second-degree relatives as well as first-degree and their ages at diagnosis. It is used to estimate both 5-year and lifetime risk, but this is not as widely used as some of these other models. There's another model referred to as BRCA Pro. This includes the patient's age and whether or not there's Ashkenazi heritage in personal factors, but no other personal factors. It does include a much more extensive family cancer history, not just breast cancer. It includes whether or not the patient has had risk-reducing surgeries and prior BRCA1 or 2 gene mutation testing. It can determine the likelihood of the patient having a BRCA1 or 2 gene mutation, and it calculates both a 5-year and lifetime risk of both breast and ovarian cancer. Another model referred to as BODICEA, the breast and ovarian analysis of disease incidence and carrier estimation algorithm, can be used in women who are already known to have a BRCA1 or 2 mutation, as well as calculate the probability of carrying one of these mutations. But this model is very labor-intensive and not widely used. At the Cuda Breast Care Center, as in many other breast centers, we use the Tyrer-Cuzick model, otherwise known as IBIS. This includes the patient's age, as well as whether or not she has Ashkenazi Jewish heritage. It includes her body mass index, and the most recent version, version 8, also includes breast density. It includes her age at the onset of menstruation or menarche, as well as menopause, age at first live birth, and whether or not a postmenopausal woman has used hormone replacement therapy. It includes results of previous breast biopsies, including benign biopsies, biopsies with hyperplasia, atypia, or lobular carcinoma in situ. It includes a family history of breast and ovarian cancer in both first, second, and third-degree relatives, along with male relatives. It can calculate the risk of having a mutation in the BRCA1 or BRCA2 genes, and it estimates both a 10-year and a lifetime risk of developing breast cancer. And when a gene mutation is identified, there is the All Syndromes Known to Man Evaluator. This was established by Dr. Hughes and his group at Mass General Hospital, and this can calculate the risk of developing cancers associated with several known gene mutations. You can input the patient's age, the known mutation, whether or not they have had any prior cancers, and whether or not she has had any prophylactic surgery. And this report also includes guidelines for management when available. And so when a woman comes for a comprehensive breast cancer risk assessment at the Cuda Breast Care Center, she'll meet with either one of our 2 breast surgeons or a nurse practitioner who runs our high-risk clinic. We will take a comprehensive family as well as personal history and perform a clinical breast exam. The patient can be referred for genetic testing when appropriate, and then we develop a personalized plan for follow-up. And so once a risk assessment has been performed, we truly know the most appropriate guidelines to use. For women who are at average risk of developing breast cancer and do not have dense breast tissue, meaning the lower categories A and B, the recommendation is for annual mammography, preferably 3D or digital breast tomosynthesis, starting at age 40. For women who have dense breast tissue, then in addition to annual 3D mammography starting at age 40, supplemental screening can be considered. Women who are then at higher than average risk, the recommendations depend on where that risk is coming from. If there is a gene mutation, or if the woman has had prior radiation to her chest between the ages of 10 and 30, then annual screening MRI is recommended starting at age 25, with annual mammography, again 3D, to be started at age 30. For someone who is determined to be at high risk, meaning greater than a 20% lifetime risk based on these models, or with a strong family history, then she's recommended to have annual 3D mammography and access to supplemental imaging, particularly breast MRI, starting at age 35 or when recommended by their physician. And frequently we will take into account the youngest age of the relative with breast cancer and start 10 years prior to that. And then for women who have a personal history of breast cancer who did not have both of their breasts removed, there are different screening guidelines as well. If she was diagnosed prior to age 50, if she was diagnosed after age 50 and does not have dense breast tissue, then annual 3D mammography is preferred. For women who are diagnosed under age 50 or have dense breast tissue, then in addition to annual 3D mammography, supplemental screening with MRI should be considered. And this is actually recommended by the American College of Radiology. And screening should continue for women at average risk as long as the woman is in good health or has a life expectancy of approximately 10 years. And I certainly encourage any woman with a history of breast cancer to be screened as long as she would like to. And so we'll spend the last few minutes talking about some of the advances in breast cancer treatment. So there are three main categories of breast cancer treatment. The first would be surgery, which involves surgery to remove the tumor from the breast and may or may not include surgery on the axillary lymph nodes or lymph nodes in the underarm, which are the first nodes that are most likely to contain the spread of cancer. The second part of treatment is radiation therapy. This is usually given with breast-conserving surgery, but sometimes after mastectomy as well. And then the third main category are medications, which can be thought of in terms of hormonal therapy, chemotherapy, targeted therapy, or immunotherapy. And so breast cancer surgery can include breast-conserving therapy, which means removing the tumor from the breast followed by radiation, or mastectomy. And removing the tumor from the breast is called a partial mastectomy, otherwise known as a lumpectomy. A lumpectomy can be performed in the majority of women who are diagnosed with breast cancer. And the goal of a lumpectomy is to remove the cancer with a rim of surrounding normal tissue, which we call our margins. Recent techniques, though, called oncoplastic breast surgery, have developed with the goal of optimizing the aesthetic result while maintaining oncologic principles. And instead of removing the cancer and letting the tumor cavity fill with fluid or a seroma, these techniques involve rearranging breast tissue in order to fill that defect. And those can be broken down into level 1 techniques, which are used when less than 20% of the breast volume needs to be removed, and level 2 techniques when between 20 and 50% of the breast volume needs to be removed. And these level 2 techniques are frequently performed with a plastic surgeon. But even more advances have been made in the lymph node surgery. And so breast cancer treatment for decades involved removal of several lymph nodes, 20, 30 or more, from the underarm. About 20 years ago, fortunately, a sentinel lymph node biopsy was developed and has become the standard of care over these last 2 decades. A sentinel node biopsy involves mapping the lymphatics of the breast to determine which lymph nodes are the first ones out of the breast, or the ones most likely to have cancer. And if those lymph nodes are not involved with cancer, then that lets us avoid removing other lymph nodes, as the likelihood of additional lymph nodes having cancer or cancer being anywhere else in the body would then be very low. But even for women who had the sentinel lymph node biopsy, if there were cancer in the sentinel nodes, for many years, this was then followed by an axillary lymph node dissection. But more recently, we have found that if only 1 or 2 lymph nodes have been affected by cancer, there are no benefits to the woman's outcomes by performing additional lymph node surgery. And one of the landmark studies that addressed that is known as Z11. But that only applied to patients who were undergoing breast conservation or having lumpectomies. Whereas another study, then referred to as AMAROS, also included patients who were having a mastectomy. And what this trial did was compare radiation to the axilla to additional surgery and found no difference in outcomes. We also now are able to do what we call a targeted axillary dissection. For many women who present with cancer in their lymph nodes at the time of diagnosis, if they have chemotherapy before surgery and these lymph nodes now become normal, we can perform what's called a targeted axillary dissection, which is essentially performing a sentinel lymph node biopsy and making sure that the previously biopsied lymph node is removed. And if the chemotherapy has resulted in no leftover cancer in these lymph nodes, then no other lymph nodes need to be removed. And all of this, what we call de-escalation of lymph node surgery, is designed to avoid the risk of lymphedema. Lymphedema is arm swelling that can result from any lymph node surgery, but fortunately is only about 5 to 7% with a sentinel lymph node biopsy, but can be up to 20 to 25% with the more extensive axillary lymph node surgeries, and even higher with the more extensive surgeries in addition to axillary breast radiotherapy. We also have developed our lymphedema prevention program, which started at Cape Cod Hospital last year, where we can monitor for the development of lymphedema using a non-invasive bioimpedance device and allow for the detection of lymphedema at the earliest stages, perhaps before there's any visible swelling or any symptoms at all, and the patient can then be referred to lymphedema therapy. There have also been advances in radiation therapy. Traditionally, after a lumpectomy, the whole breast has been radiated, known as intact radiotherapy. But more recently, this technique has shortened the traditional course from 6 to 7 weeks down to 3 or 4. So the woman gets treated between 15 and 20 times. There is another technique of whole breast radiation as well, in which the woman gets treated only once a week for 5 times. These were studied in what they would call elderly patients. One study defining elderly as 70 and over, the other landmark study with the average age of 80. And this regimen was especially recommended for women with early stage disease who had other limitations, either lots of significant diseases or social or functional limitations that made these more conventional regimens for radiotherapy not feasible. But they also have developed techniques of partial breast radiation, the most common one still being 15 treatments or 15 fractions to the same total dose, but radiating only the area of breast tissue around the lumpectomy. And partial breast radiation can also be given in an accelerated form with a slightly lower total dose of 30 gray, but given in 5 every other day fractions. And we also have data to support omission of radiation. For women who are over the ages of 65 and 70, who have what we would consider favorable tumors, meaning hormone-sensitive cancers that are smaller than 3 centimeters, with negative or good surgical margins, these women have been shown to have no difference in survival with the addition of radiotherapy. But this does imply a commitment to 5 years of endocrine therapy, otherwise called hormone therapy, which again is applicable to women who have hormone-sensitive cancers. And so hormone-sensitive cancers have been shown to benefit from endocrine therapy for the last 40 plus years. But more recently, guidelines have expanded this to hormone receptor positive ductal carcinoma in situ, or non-invasive breast cancer. And this is now included in the National Comprehensive Cancer Network guidelines for the treatment of non-invasive breast cancer in women who have had a lumpectomy or women who may have had a mastectomy but retain the other breast to reduce the risk of breast cancer in the opposite breast. But we also have advances in the treatment of invasive cancer with regard to endocrine therapy in deciding which patients would also benefit from chemotherapy in addition to the endocrine therapy. And this is what we call genomic testing. For cancers that have estrogen receptors and do not have the HER2 receptor and have not spread to the lymph nodes, genomic testing can estimate the benefit of adding chemotherapy to endocrine therapy. One of the most commonly used tests, which is used at Cape Cod Healthcare, is something called the Oncotype DX. This is a 21 gene assay that, when it was initially used, came out with a recurrence score in which women fell into a low, intermediate, or high risk category. But then the TAILOR-X study, which was published in 2018, essentially randomized women in the intermediate group to receive chemotherapy or not, and basically eliminated that intermediate group. So now women fall into a high or low risk category. And then last year, they published additional study known as the RxPonder trial, which included women who had limited spread to the lymph nodes, between 1 and 3 lymph nodes involved with cancer, and showed that women who have these lower scores, who are postmenopausal, don't benefit from the addition of chemotherapy. And then lastly, there are advances in targeted therapies. HER2-positive disease has been treated with a drug called Herceptin or trastuzumab for several years, and then there's a second drug now called pertuzumab, and these drugs can be given either before or after surgery. There's another drug known as Cadcycler or TDM1, adotrastuzumab emtansine, that can be given after surgery if the chemotherapy has not eradicated the disease. And then another drug called Enhertu for women who present with metastatic or unresectable disease. There's targeted therapies for the triple-negative breast cancers, meaning cancers that don't have estrogen, progesterone, or the HER2 receptor. Pembrolizumab or Keytruda can be given for these cancers that are high risk. And capecitabine or Xeloda can be used in women who have residual disease after chemotherapy. There are targeted therapies available also for women who are BRCA1 and 2 mutation carriers. There's a drug called olaparib that's given in these women. And then a drug called Verzenio or abemaciclib for women who have hormone receptor positive HER2 negative cancers that are considered early stage but have spread to the lymph nodes, or for more advanced or metastatic disease. And so while we have all these new advances in treatment, Benjamin Franklin said it best, an ounce of prevention is worth a pound in cure. And so get your mammograms. And although you may not actually be able to do a mammogram online, you can certainly schedule one online, either through the Cape Cod Healthcare website linked to your MyChart, directly through your MyChart, or with a phone call. So I'd like to thank you for your attention, and I'll turn the talk over to Dr. Sidhartha.
Thank you, Dr. Oxley, for that excellent presentation. It was so useful to have that clarification around the variations in different guidelines that are out there, the confusion around it, and how you were able to kind of distill that and share it with the audience. So that was excellent, and also making sure that we all are aware of the guidelines on screening, the importance of 3D mammogram, the accuracy of that, and which is available with Cape Cod Healthcare, and also the gene assays that are available with us. So thank you for that. For the next session, we'll switch gears to talk about primary prevention that Dr. Oxley referred to earlier. So that is even before going upstream and addressing prevention of the cancers from happening at the first place. And I'll walk you through different elements, focusing initially on the nutrition part, and then at that end, I'll wrap up with on how you could make changes practically in your lifestyle to make that difference. So the numbers, Dr. Oxley explained it in more detail than I've listed here, so I don't think I need to emphasize that in this slide. So there is definitely a difference in understanding that nearly around 10% of the breast cancers are strongly connected with the genetics and heredity, and then the remainder there is influence of both, and 30% of the breast cancers in the US can be prevented through healthy nutrition and controlling excess body weight and physical activity. And avoiding smoking and cutting back on alcohol are, again, other key strategies that can help you to prevent breast cancer. So the outline, I'll touch on carcinogens, exposure to carcinogens, and explain how actually cancer cells are born. Touch on nutrition, alcohol, and then body weight and its role. See, one of the things I've come across in seeing patients over the years is how much of fear is out there around cancer, and rightly so, because of the devastation it can cause. And I see that part of the reason for the fear is also the unknown around it, in terms of, you know, how it attacks us, and not knowing where it comes from. So breaking that down, I feel, will help to understand, educate, and empower you, so that you can feel that you could take charge of your health to prevent cancer, and without fear. And I think so. My attempt here in the next few slides is to kind of break it down, so that the unknown element is not there on that. So what are carcinogens? Carcinogens are cancer-inducing entities, and I would emphasize the word induction or inducing there. And they are either chemicals or viruses, you know, the HPV virus, hepatitis C viruses, and so forth. And cancer induction, that technical term induction, is basically the birth of cancer cell, where a normal cell turns into a cancer cell. How does it happen? Simplistically, a normal cell has its DNA broken in certain areas, and these are the DNA that are protective, that has protective genes. So Dr. Oxley referred to the BRCA gene earlier, and there are other genes also that the human body has, like the P13, that protects other organs like colon cancer. And so there are many of these protective genes that we are born with, that is built in when we are born. And when there are breaks in this DNA, what technically is called as mutations in a technical lingo, but I'm calling it a DNA break here. And when that happens, that cell becomes a cancer cell. Now, many times the body is able to reverse that process and bring that cell back to a normal cell. And that happens in an industrialized world. Many of us were exposed to the stressors, the industrialization of the chemicals, and other environmental things, and the lifestyle and food. We all have cancer cells that are born, but the body reverses them back to normal. This happens regularly every day for most of us. So that's why not everybody gets cancer, but some do. And the unfortunate individuals who get the cancer is where those cancer cells start to divide into two. So that genetic break that happened, that cell becomes 2 cells, and those 2 cells become 4, and they all carry that broken DNA, that DNA break, the defect is there. So that's how a cancer cell happens. These DNA breaks, sometimes they happen as part of the genetic error at birth. So that is the 10% of the cancers, and in the remainder 90%, it happens as that person is growing up. So those DNA breaks, those mutations are happening during adolescence and during adulthood, and that is due to exposures, that is due to lifestyle, and that's the area where there are opportunities to modify that lifestyle, reduce that risk, and increase the protection that we'll talk about. So again, as I said, not all cancers proceed to become an established, not all cancer cells proceed to become an established cancer. The body can revert them back to normal, and the nutritional factors determine whether there is risk or opportunity in that cancer, the seeds of this cancer from becoming an established cancer. And it has a lot to do with the menu, our meals, and we'll talk more about that. And what I will talk in the next few slides is on how a higher level of animal protein can increase the growth of cancer cells, a higher level of antioxidants and plant nutrients called phytonutrients can protect against cancers, and also a higher level of dietary fiber is key to make sure cancers like breast cancer, hormone sensitive cancers in general, prostate and breast cancers, can be affected by having enough dietary fiber, which can protect against hormone sensitive cancers. And so just to kind of put a list on the food related factors that determine cancer risk, the human made toxins, chemicals that are carcinogens, dietary fiber We'll touch on antioxidants, phytochemicals, and the type of protein that is consumed. So this is one way to look at that. It's kind of a decision tree starting from the food. To your left, what you're seeing is the kind of the human-made artificial toxins, pesticides, fertilizers, things that are in the food chain. And then the other elements that I mentioned there, the chemical preservatives, they don't directly cause cancer. There's not data to support that, but they challenge the immune system. And I can tell you a little bit more about it in the other slides, how it can tax the system. And while the system is busy dealing with those things, cancer can establish in that sense. So and then in the middle, in the decision tree, what you see is the non-nutrients, that is the dietary fiber, antioxidants, and phytochemicals. And what you're seeing to your right, we'll talk about is the nutrient piece, which is, we'll talk more on the protein aspect of that. So just to kind of give a sense of the proportions in our plates and meals, and when you look at our daily menus and a weekly menu, what proportion is animal protein, what proportion is plant protein? Just kind of giving you a broad insight into that, to kind of start thinking about it as we are going to do a deeper dive on that. So what we know that is that for the given amount of carcinogen exposure, for the same amount of carcinogen exposure, the level to which that carcinogen can induce cancer and grow cancer can be controlled by the amount of protein, especially animal protein, that is consumed. So studies have shown that if just by increasing and decreasing the protein level, the animal protein level, you can switch off and switch on the cancer growth proliferation rate. What you're seeing in that graph, this is using a carcinogen exposure and looking at introduction of protein that contributes to 5% of the daily calories, and then switching it to protein that contributes to 20% of daily calories. So just going back and forth between the two, you could see that the cancer grows when it's 20% protein consumption, and then the cancer is shut down or nearly shut down when the protein level is brought down to 5% of the daily calories. And then again, you can turn it on with 20%. So it's amazing to see how regardless of the exposure to carcinogen, the trigger, the level of progression to cancer can be controlled by the level of animal protein in the diet itself. So in this chart, what you're seeing, what you see on the top, those two kind of stems that are coming out, one says high C, the other one says low C. What that really means is that it's a high carcinogen exposure and a low carcinogen exposure scenarios. And you can see that even with the high carcinogen exposure, even though the cancer initiation happens, the first series of cancer is set. Then with the optimal diet, with the switching to more plant protein or drastically minimizing the level of animal protein, but at the same time making sure you're meeting the protein needs with adding more plant protein, you're going to actually slow down the progression of the cancer, even with a higher exposure to carcinogen. On the other side, you're seeing a low exposure of carcinogen, minimal exposure to carcinogen, but still with a diet that has a higher level of animal protein, the cancer progression is speeding up. So here I would like to briefly talk about this food chain and how carcinogens are upcycled. I get this question when I'm seeing patients, post-diagnosis, after, or even before a breast cancer diagnosis. Questions about, should I eat organic? Should I, how can I cut back on chemicals? How can I protect myself from, any other exposures, water? It can feel so overwhelming and disempowering when we're trying to figure out how can I avoid all these kind of toxins and how can I protect myself. And I'm trying to show you in the next couple of slides how eating more plant foods simply is one of the best ways to, one of the efficient ways to reduce the amount of exposure to carcinogens. So what you're seeing there is a food chain, sun exposure, vegetation grows that are eaten by herbivores, and then omnivores, humans, we consume that. So what we know from concepts such as what is called as bioamplification, that carcinogens, when they, and chemicals, when they enter the food system, they are upcycled as they move up through the food chain from one level to the next level. The concentration goes up. In other words, 1 gram of broccoli and 1 gram of tissue of chicken or beef, when you compare them gram to gram, the concentration of carcinogens will be higher at the higher member, that is at the higher of the food chain. And the reason for that is physics. We won't go too much into that, but there's something called the laws of thermodynamics. The second law of thermodynamics basically says that energy always moves from higher concentration to lower concentration. So sun exposure to plants, to herbivores, and up the cycle. And some of the energy is always lost. So what that means is that 1,000 units of plants support 100 units of herbivores, 100 units of herbivores support 10 units of omnivores. That is the way it is in the world because of physics laws. And what that means is that all the carcinogens that were in 1,000 units of plants will end up in 100 units of herbivores. All of that is in the 100 units of herbivores will end up in the 10 units of omnivores. So it's called bioamplification, where the concentration goes up. So if somebody comes and asks me, how can I reduce my exposure to other stressors to my system and cells, or should I go organic? I can't afford organic. Simplest way is to kind of climb down the chain of food chain and eat at the lowest end of the food chain. So what you're seeing, those numbers are basically the amount of calories that are distributed, but I simply explained how that the number of members that are supporting at a higher level is only a smaller number. So that is on generally on toxins, carcinogens, and how food chain and where we eat at the food chain matters. Then we'll switch a little bit to talk about fiber, dietary fiber. So nearly 2 out of 3 breast cancers are hormone sensitive, and excess exposure to hormones, when the breast tissues get exposed to excess level of the hormones, there is a risk for proliferation of the tissues, for cancer to establish. And body has inbuilt mechanisms to keep a check on those excess levels of hormones floating in the system, what we call as technically homeostasis, where there is kind of a balance yin and yang set by the body's own mechanisms, so that too much of anything is not happening. And that is happening because of a particular protein that is in the blood called sex hormone binding proteins. And these are proteins that bind to hormones such as estrogens, even in men, and with testosterone as well. So here on this particular topic, we'll focus on the breast tissue exposure. And so when the protein, the sex hormone binding protein, binds to the estrogen, for example, that reduces the amount of free unbound estrogens floating in the system, which when that level is excessive of those free unbound estrogens, that is a risk for breast tissues to be growing, proliferating into a cancer cell. If there's a cancer cell, that will also be stimulated. So having a regulation or a control over the level of sex hormone binding protein helps to make sure that there is a check on these free unbound estrogen levels and hormone levels, and that is achieved by the dietary fiber on your meal plate. So the more fiber, the dietary fiber is there in your meals, that helps to have enough amount of sex hormone binding protein in your system, and that allows for having a control over the level of exposure of the breast tissues on the free unbound estrogens. Again, giving an idea of a low dietary fiber breakfast on the left and a high dietary fiber breakfast on the right. So how does it happen? Dietary fiber doesn't work by itself with that. It's the gut bacteria, the microbiome, which we are learning to understand more and more about these days. So there is a collaboration between the dietary fiber and the gut microbiome to help with regulating and controlling the estrogen levels. The gut microbiome also facilitates the body's ability to
eliminate excess estrogens through stools. So that's also a normal mechanism body has to make sure the balance is maintained on the level of estrogens that the breast tissue is exposed to. So, and there are other mechanisms that the dietary fiber helps. As I said, it helps enhancing the intestinal elimination of the excess estrogen. It regulates insulin levels and sugar levels when we eat dietary fiber. And the insulin level matters because insulin in turn can control estrogen levels. And then and dietary fiber also makes sure that we are not eating too much caloric foods because we get full with the dietary fiber. We're not going to eat much more. So that kind of helps to make sure our body weight is not going excess to control optimal weight. And it also helps to maintain the healthy bacteria in the gut, which becomes important to regulate the estrogen levels. So foods with a higher level of dietary fiber, non-starchy vegetables, leafy greens, fruits, legumes, whole grains, nuts, and seeds. Again, an example of a low dietary fiber meal. All animal products, as we know, have zero dietary fiber, and most wholesome plant products have dietary fiber. And there might be lacking in some of the fruits, even though they may be wholesome, but generally more on the plant-based foods. A little bit on the antioxidants and phytonutrients. As I mentioned earlier about how the DNA breaks happen in the cells where a normal cell turns into a cancer cell with that mutation, the broken DNA I mentioned. Well, when that happens, that usually happens because of the carcinogen exposure. So the body tries to neutralize any kind of a foreign entity, like any man-made chemicals entering into the system. Body tries to deal with that and neutralizes it. As it tries to neutralize it and eliminate from the system, there are some byproducts produced at a cellular level in the tissues, and those are called oxidants. Oxidants are really called free radicals. There is another name for it. What that really means is they are like a high energy bull in a china shop situation. So you've heard of the bull in the china shop. It's going to break things, right? So that's what happens with the carcinogens. The body neutralizes the carcinogens. There are more oxidants produced, free radicals, that kind of breaks this DNA and causes the broken DNA and establishes the seed for cancer, so to speak. So, so if the problem is happening because of the oxidants and free radicals that are produced because of the effect of carcinogens and the body trying to deal with them, then what will help to neutralize those oxidants, right? The opposite, antioxidants. So the antioxidants that are present in colorful fruits and colorful vegetables helps to neutralize the oxidants so that there is not much DNA breaks are happening in the cell. So it basically, if you think about my analogy, the bull in the china shop, it makes sure that breaks are not happening there. So oxidants, as I said, are the color in vegetables and color in fruits indicate the presence of the pigments, and the pigments pigments are the antioxidants. So that's key. I always remind folks that color, not all color means it's healthy. So we all know M&Ms have different colors. So keep that in mind. So it's the colorful fruits, colorful vegetables to think about. Also, cacao powder, using which chocolate is made. Cacao powder is also has one of the highest antioxidants as well. Again, leafy greens, another one that is on the top, and there are some legumes and some nuts and seeds as well that are high. So, for example, sunflower seeds high in vitamin E, for example. And then phytonutrients, phyto, kind of I think a Latin root word indicating plant. So plant nutrients, these are naturally occurring nutrients and chemicals that are not man-made, naturally occurring chemicals called phytochemicals. And they help not only to deal with this oxidant damage of the cells, but also even after a cancer is established, somebody who's diagnosed with cancer, it helps to reduce the rate of division of those cancer cells. So those two cancer cells from becoming 2 to 4, 4 to 16, and so forth, how fast that multiplication happens, that division happens, can be slowed down by this phytonutrients. So again, rich in leafy greens, fruits and vegetables to reduce that. So, so that covers, the non-nutrients we wanted to talk about, the dietary fiber and antioxidants and phytochemicals, and then we'll switch gears to talk about nutrients, specifically focusing on protein. So here I would touch a little bit on how protein, especially animal protein, can stimulate something called insulin-like growth factor in the body, insulin-like growth factor, IGF-1. And that is essential for a kid to grow into an adult, right? So for the body to grow, we need IGF-1. But when there's excess stimulation of this IGF-1, when there's so much of it floating around, too much, over excessive, then that can actually set the stage for future cancer. So we do know that women who are tall have a higher risk for breast cancer. Now, the height is determined during adolescence and growing up. And there is some evidence, put some references there, that points to the idea that the food factors and also how that can stimulate the IGF-1 and set the growth to the adult size, but also can be a risk for future cancers, especially if those particular lifestyle and diet continues into the adulthood. So is the opposite true? If taller women have higher risk, is the opposite true that there could be a lower risk? Yes, there is. And we know that from studying a particular group of individuals called who have a genetic disorder called Laron syndrome. Laron syndrome is where there is a genetic deficiency of this insulin-like growth factor 1, IGF, that I mentioned, which is required to grow from a kid to an adult size. But also after becoming an adult, after that stage, when we have excess IGF-1, that becomes a risk for cancer because it starts to grow tumors once after we have reached the adult size. So in this Laron syndrome folks, yes, they have a deficiency in IGF-1, but what is interesting in that is that yes, they are dwarfs, but they are also immune to cancer. So so this group of individuals never get cancer, and they never get diabetes as well, and it is impossible for them to get it. So they have been an interesting, fascinating field of study in science to understand what is going on there, why they're not getting cancer at all. And we know that it's due to the IGF-1 lack. So if lack of IGF-1 makes it immune for cancer, against cancer, then when we have excess IGF-1, that can lead to more cancer. Again, there is more evidence for that. This just shows the connection between growth hormone, IGF-1, and how it works to kind of have us grow to the adult stature. And this talks about how protein, especially animal protein, stimulates IGF-1, excessive IGF-1 happening after we become an adult. At that point, there is no need to have excess IGF-1 floating around. At that point, it is a risk to have excess IGF-1. And this study is basically showing what you're seeing in the 3 graphs is the level of protein that is consumed, with the black bar showing the high protein level, and the grade 1 on the other end is the low protein level. And on the y-axis, and the tall y-axis, what you're seeing is the blood levels for IGF-1, and it's clear correlation between the amount of animal protein consumed and the IGF-1. Higher the animal protein, higher the IGF-1 level. And they also looked at a correlation with that higher level of IGF-1 and incidence and occurrences of cancer and mortality, death from cancer. So there is a direct correlation between all of that factors. Higher protein, animal protein, higher IGF-1, higher cancer rate, higher mortality from that. Again, the references are put in there. This is something I just want to touch on it. I won't go too much into that. This is about after a cancer is established, right? So the cancer tries to spread to other organs, to the nearby areas and to the distant organs even, which is devastating for the individual. And that cancer does that through a very kind of a cunning, clever way of creating its own highway to travel, so to speak. So cancers can establish circulation, blood vessels, channels where it can travel to nearby organs, distant organs, and that is called angiogenesis. Angio, blood vessel, genesis, creation. Angiogenesis is just, it starts to put new blood vessels and start to travel. So there are, and there are certain foods that are listed here that work as an anti-angiogenic foods that actually stops the cancer cells from putting those travel pathways for it to go elsewhere. So again, I think this list, we won't read through the list. You have it there, and you can also check that in the recording when you are checking the recording later on. So again, anti-androgens foods, lots of plant foods, basically. It's interesting how you would see that the same kind of a group of foods that I'm talking about that has the dietary fiber are the same foods that has the antioxidants and phytochemicals, and are the same foods that also can stop the cancer cells from putting blood vessels to travel. So it just all connects the dots there. And excess body weight is a risk factor. And there are multiple studies, I've listed it here, that has shown how each 5-unit increase in the body mass index can actually increase the risk of breast cancer by 10%. So it's kind of an incremental increase. There's a strong kind of a dose response correlation, what we call as dose response, which is a very strong indicator that there is a connection. And that is because of excessive IGF-1, as I mentioned, excess insulin levels, and also the excess body fat tissue can actually produce estrogens as well, and that also becomes a risk for breast cancer. So again, it's one of the ways to reduce excess body weight is also to make sure that the foods that we consume are not calorically dense, but more like nutrient dense and high in dietary fiber, so that not too much calories are coming in. So the other one that is worth noting here is the alcohol and its the risk it poses for breast cancer. For every 10 gram per day daily consumption of alcohol, the risk for pre and postmenopausal breast cancer increases by 5% and 9% respectively. So 10 grams is kind of a one standard drink portion. And alcohol does it through multiple mechanisms. It increases the estrogen levels, either by converting the androgens to estrogens, or it comes in the way of the liver's ability to break down excess estrogen. And alcohol can also increase the level of IGF-1, which we talked about earlier. And alcohol can also dampen the effect of the protective gene, the BRCA gene as well, what we call as down regulation in technical lingo. And this is, again, the reference for that. So generally, I think when we think about nutrients, one of the things I want to remind everyone is that, yes, there are phytochemicals in some foods. Yes, there are, blueberries have anthocyanins, and there are different pigments and antioxidants in different foods. But it's important to remember that there is no single MVP in this arena. There is no superfood. It is to do with the combination, the mix of ingredients that comes into our body over a week's time. What's a weekly menu looks like, right? It's not about that one superfood. Having, I don't know, kale, broccoli 3 times a day is not going to solve the problem. It's really about the combination, the mix of everything that comes in. So I've just kind of illustrated showing that how nutrients are at the core, but then it's about the food, but it's more about the pattern of meals. And there are 2 patterns of meals that are kind of popular and well known these days. One is the Mediterranean diet, and the other one is the whole food plant-based diet. They both are very heavy on plant foods, as you can see on the left side, Mediterranean diet. Heavy amounts of vegetables and fruits, nuts and seeds are included. Fish is included, olive oil, olives are included, poultry. We go to countries like Sardinia and certain Mediterranean areas, poultry is once a week maximum. So that's kind of the Mediterranean diet. The whole food plant-based diet is virtually all plant foods, all the nutrients coming from plant foods, including legumes for protein, whole grains for protein, vegetables and fruit for the fiber and the antioxidants, and nuts and seeds in a small degree. So how to apply? How do you, learning this, if you want to go and think about making some change, how do you start applying it? Where do we start? Simply I start by saying filling up half the plate, dinner plate, with at least 3 colors of vegetables. If you want to start, you can start with 2 colors, but you really want to get to 3 colors of vegetables. So that's a basic way to start, looking at how can I increase the portion size of colorful vegetables on my plate, and then shifting grains to whole grains. And if you're eating pasta, semolina, going to whole grain pasta. Adding more dietary fiber other in through snacks, for example, so carrots with hummus, fruits, different fruits you're adding for breakfast, you're adding for snack. And then thinking about how can I switch my protein to not only avoiding the risk from animal protein, excess animal protein, but also taking in protein that has dietary fiber. That'll be plant protein, maybe 1 dinner a week, and then go to 3 dinners a week, adding a veggie burger, beans to the pasta dish, or a bean chili, burritos, and so forth. So just to kind of wrap it up, individual nutrients are not the area to focus on. It's the collective amount of nutrients that comes in a weekly menu, the mix, the pattern of meals. Choosing plant-based meals for as many meals as possible reduces the risk for breast cancer by optimizing weight and also addressing other risks. Maintaining ideal body weight through the diet and by exercising, which burns the calories, is important. And then limiting alcohol consumption and avoiding smoking is fundamentally key as well. I put on some resources there if folks want to explore how to make those changes, including for diet, for smoking cessation, and for physical activity. And at this point, we will be doing the Q&A. So keep the questions coming through the chat box. And I know that some of you have already shared questions that we will be fielding them now. And at the end of the program, we'll have roughly around 7:30 up until 7:30. After that, if you miss out on writing questions, we'll take questions by email. I'll share that later on. So thank you for your attention.
So we have one question that came in that had to do with whether or not insurance is covering some of these supplemental screenings and what would then be recommended. So when 3D digital breast tomosynthesis was first introduced, it was not uniformly covered by insurance, but there was an incremental charge of between around $50 and $75. Now I'm not aware of any insurance companies that are not paying for 3D digital breast tomosynthesis. The MRIs, the answer to that is it depends. And that's really where this risk assessment comes in. Because if someone is determined to have a 20% or greater lifetime risk of developing breast cancer, then the insurers are almost across the board covering that test. And then for someone who is at elevated but not technically high risk, we do have the fast screening MRIs available, which are available with an out-of-pocket cost of $450. And so I recommend that every woman have a formal breast risk assessment who's 25 and older to really determine what the most beneficial screening would be. But certainly all 3 Cape Cod Healthcare breast imaging facilities now offer digital breast tomosynthesis.
I have questions around soy. Is soy safe to eat on a plant-based diet? And another question is soy safe to eat when one has had breast cancer? So this question has been swirling around for many years with some confusion, but I think the recent data that we have gathered in the past few years have clearly shown that eating unprocessed, wholesome soy products on a regular basis, 1 to 2 servings, not exceeding 1 to 2 servings a day, helps to prevent recurrence of breast cancer. And the same thing can be said for preventing breast cancer in the first place as well. So there are studies like the Shanghai Women's Health Study that looked at thousands of breast cancer survivors and compared their diets to find out whether soy was hurting or helping. And that was just one study, and additional studies have shown clearly that how the phytoestrogens in the soy actually is helpful. So the unprocessed wholesome soy, there are 5 products in that. Edamame beans that you can buy in stores and throw it in your salad. a complete protein right there, soy milk, tofu, fermented soy, which is tempeh, and soy nuts. Those 5 products are wholesome and processed, and that has been shown to be safe. If you have a thyroid condition, you want to kind of make sure that you're checking the thyroid. Um, generally, 1 to 2 servings soy per day is safe, even for thyroid situation.
So we have another question. How can a woman concerned about her risk factors be referred to the high-risk program? So that's a great question. And again, a formal risk assessment should begin with a primary care provider or a gynecologist. But if someone is not able to have the conversation they want to have, we can certainly arrange a consult at the Cuda Breast Care Center. We don't offer an online appointment scheduling, but absolutely give us a call. We're listed on the Cape Cod Healthcare website, and our phone number is 508-957-1720, 508-957-1720.
I have a question here. Is there a recommended number of fiber grams daily? So there are some minimum requirements that goes from at least 15 to 17 grams a day. That is setting the bar low to begin with. I will say that. So even though that's a low bar, many Americans not even meeting that. So my recommendation is to see at least if you can hit to 20, and based on. But if you're never used to eating fiber, vegetables at all, then start low and go slow, so that you're allowing time for the gut to get adjusted to the amount of fiber. And there are some rare conditions during an acute flare-up of a bowel condition like Crohn's and all, you need to not do fiber. So those moments are different and unique, but what I'm giving is a general recommendation to prevent any of those chronic diseases.
We have another question on screening after mastectomy. Someone said, after I'm done with chemotherapy for breast cancer, how do I know the chemo did its job because there's no more screenings? And so no, there are no recommendations for routine imaging of the breasts if both breasts have been removed, but there are recommendations for clinical follow-up. And I didn't really talk about a breast self-examination. That doesn't actually fit into the majority of guidelines for women who are felt to be at average risk of breast cancer. However, I do think that a breast self-exam is very important in a couple of different groups, specifically for women under the age of 40 who aren't having routine screening. Breast cancer certainly does occur in women under the age of 40, and those women aren't getting routine imaging. So a breast self-exam or just getting to know what your breast tissue feels like means if something changes, you can let somebody know and get that evaluated ASAP. But for women who've had breast cancer and have had mastectomies, a physical exam and a self-exam are also very important. And a woman who's been diagnosed with breast cancer is going to be followed very closely every 3 to 6 months for the first few years, annually, and can be followed really as long as she wants to be on an annual basis. And then if there are any abnormalities felt on a breast or chest wall, then we would absolutely perform imaging. But it would not then be for the purpose of evaluating this abnormality, not a routine screening.
I have a question regarding recommendations for eating in restaurants. So I get this question a lot. So generally, I would say make sure you look at the sides part of the menu. There is always vegetables and all that is included in that. So any of those that you could order will be great to add more to the dietary fiber, the phytonutrients and antioxidants you can bring in. And it's always good to start with a salad and make sure that it has different colors in it, different ingredients that comes into that, and minimize the animal protein if you can in the salad. You can ask the restaurant to kind of add some nuts to it if need be to get the protein. Yeah, generally I think looking at just the portions, what's on your plate, making sure that it's heavy dominated by vegetables, greens, and protein going, if they don't have options other than animal protein, then making sure that the portion size is small. And the other question I have is fish okay to eat 2 to 3 times per week? Yeah, I mean, I think it's really about, I don't know, I mean, the person who asked the question, I don't know the individual risk level for this individual. You know, it all depends upon where you are with your health. Uh, what is your story with regard to cancer? You know, are you trying to prevent it, being proactive? Is this, you know, did you have cancer recurring? All of that matters. I think it's really about what the health situation, the status is, and how aggressive you want to be in terms of proactive steps to prevent cancer. And that, if you want to be really aggressive, then yes, the portion size and the frequency, I would say, of the fish intake needs to be less. But again, it's all about where you want to be, focusing more on other, you know, adding more colorful vegetables, fruits, adding legumes that has fiber for the other days, the remaining days, is important to start with.
Okay. And we have another question about risk-reducing medications. So for someone who has had breast cancer and is at higher risk, the medications that are recommended are really, in large part, treatment. For women who have had non-invasive breast cancer, the endocrine therapy is not necessarily treatment, but risk reduction. But these same medications, these endocrine therapy drugs like tamoxifen and the aromatase inhibitors, anastrozole, letrozole, exemestane, these drugs, when taken once a day for 5 years, can cut the risk of developing breast cancer in half. And so if someone has a 30% risk of developing breast cancer over her lifetime, that would be cut down to roughly 15%. And so there are risks involved with any medication. So this risk-benefit ratio obviously needs to be weighed very closely. And again, a discussion either at the high-risk clinic or at oncology for someone who's had a cancer diagnosis could best determine who's going to benefit from these medications.
Question about dairy products, are they safe? Question mark. And how much, if any, to consume? So generally, you want to look at the totality of the exposure to different types of protein in the week, right? So if, and depending upon that, the level of dairy protein is going to be a concern, or maybe not, depending upon how frequently the dairy consumption is. So I would, yes, it's an animal protein, so it has the same risks when we think about you know, cancer risk. What I didn't go into detail at that time is when there is excess animal protein contributing to your daily calories, that's when the cancer risk increases. So what is that threshold, right? The threshold really is that when your daily calories, when you look at the total daily calories you're consuming, and when more than 12% of those calories are coming from protein, animal protein especially, then that's a risk. So I would say, for practical ways, if you can switch the dairy to a non-dairy option, the market is exploding with all the non-dairy options these days, do that. That's the best way to switch it. But if you really want to stick to it, I would say just keep it minimal, once or twice a week, and that might be the way to go.
So we have another question: do hormone blockers increase the risk of other cancers? So tamoxifen can increase the risk of endometrial cancer in postmenopausal women who still have their uterus, meaning have not had a hysterectomy. But that is only for postmenopausal women, and that risk is very small. And so as long as someone is having regular GYN follow-up, those drugs can be given safely. For someone who also has a diagnosis of osteoporosis and is considered to be at high risk for breast cancer, but doesn't have a personal history of breast cancer, invasive or non-invasive, there is another drug similar to tamoxifen called raloxifene or Evista that is essentially an osteoporosis drug that can lower the risk of breast cancer. Both tamoxifen and raloxifene are good for bone health. Raloxifene is used only for risk reduction, but it does have a lower risk of endometrial cancer than tamoxifen.
A question, it says, are selenium or iodide supplements recommended for prevention? And that's all it says. I'm assuming it's for prevention of the breast cancer topic that we're talking about. My general answer to that is that for any cancer, supplements, they've looked at different supplements, different trials. They have shown to be not be effective to prevent cancer. In some studies, they have shown to actually increase the risk for cancer. So simple answer, supplements to prevent breast cancer, there is no data to support that.
That's for you.
Are there any other diets outside of Mediterranean or plant-based that you recommend to minimize cancer risk? Yeah, I mean, I think I don't want to, I don't want to get stuck with a name here, Mediterranean plant-based. The idea here is that any diet, however you want to call that, the science shows clearly that the key is to maximize dietary fiber, increase antioxidants and plant nutrients, phytonutrients coming through whole food, not through supplements, whole foods. Avoid excessive animal protein. So doing and then making sure you're getting enough the dietary fiber that I mentioned. So this is the strategy. So whatever diet names you want to put to that, I think as long as you can achieve that to go to the maximal levels of these strategies, you're on the right track. It just so happens that these two diets that are out there, Mediterranean, whole food, plant-based, they seem to have many of these ingredients already built in, and the whole food, plant-based being a little bit more on the higher side of protecting between the two diets. So I can't think of anything outside of these, but these two happens to have all the ingredients that is essential in this discussion, with the plant-based, whole food plant-based having a little bit more of the protection.
Now we have a question about metastatic breast cancer and what % of breast cancer becomes metastatic. That depends largely on the type of breast cancer, but fortunately, less than about 10% of breast cancers are metastatic at the time of diagnosis. The triple-negative breast cancers do have the highest risks, but then the risks decrease significantly with time. However, the hormone receptor positive breast cancers have overall lower risks, but these risks don't really go away. They lessen, but they never really go away. But fortunately for these estrogen receptor positive cancers, the effects of taking the hormone therapy, the endocrine therapy, even though you're only taking it for 5 years, the effects can last for 20 or more. And some women with higher risk cancers will be recommended for an extended course of hormone therapy as well, up to 10 years. So another question about lobular carcinoma in situ. So lobular carcinoma in situ is considered a high-risk lesion. And generally speaking, it is still operated on to essentially confirm the diagnosis with an excisional biopsy, or sometimes called a lumpectomy. But it's really just to confirm the diagnosis, make sure there isn't actually cancer. And then these women are going to be at least 4 times higher to develop, more likely to develop breast cancer, and so would be monitored traditionally with annual mammography and annual high-risk screening MRI exams, ideally spaced 6 to 12 months apart, and a clinical breast exam every 6 to 12 months or once or twice a year as well, again, along with breast awareness. So we have a question about radiation treatment for the thyroid being at increased risk of breast cancer, no, the radiation that's known to increase the risk of breast cancer is thoracic radiation, so chest radiation, sometimes also called mantle radiation, which has been given historically for lymphoma. So chest radiation between the ages of 10 and 30 increases the risk of breast cancer. And another risk about the radiation from 3D mammography, there's very little difference in the radiation between 2D and 3D, and a mammogram is really not significantly higher than just daily ambient radiation exposure. You get more on an airplane.